Thank you very much for this introduction. Let me to congratulate the organizers of this very useful initiative and for allowing me to participate to this very interesting session. So my first slide illustrates how the care of patients with cerebrovascular heart disease are organized in France. Locally at Lariboisière Hospital, our referral center for rare vascular diseases of the brain and eye brings together all the experts involved, which allow us close interaction between a vascular neurologist, ophthalmologist, neurosurgeon, neuroradiologist, the team of psychologists, the social worker when it is needed, the neurovascular genetic lab, and the patient association. At the national level, we have a network of expert centers. As you can see on the map of France, which can deliver appropriate care as close as possible to where the patients live. And we have also an associated referral center for children, which has been labelized a few months ago. Our referral centers is dedicated to all the monogenic cerebral small vessel diseases, including COL4A1 angiopathy due to glycine mutation or stop codon, but also to PADMAL due to an upregulation of COL4A1, to CADASIL, which is the most frequent hereditary small vessel disease of the brain and due to cysteine mutation of NOT3 gene, to CARASIL and the autosomal dominant form of HTR1 angiopathy, and to CARASAL due to CTCS mutation, and to the hereditary forms of cerebral or amyloid angiopathy. And most of the patients who arrived in our center arrived with a suspicion of small vessel disease of the brain before the very precise diagnosis has been made. And in these situations, there are two questions. The first one is, do we confirm that this is a rare small vessel disease of the brain? And the second one is, which of this monogenic cerebral small vessel disease? And to answer the last question, are there clinical and imaging clues to identify the different genetic SVDs? We already talked about all the points who can suggest COL4A1 angiopathy due to glycine mutation, such as, for example, beginning of the disease during childhood or in fetus, if the presentation is more hemorrhagic than ischemic, if there is a multisystemic involvement, including eye, kidney, heart, and muscle. For imaging clues, we see that porencephaly, the typical characteristic of the leukoencephalopathy, the observation of an aneurysm located in the siphon, or tortuosity of small arterial of retinal can suggest the disease, but some patients arrive without all these relatively specific points and only with some markers of small vessel disease which are unspecific. But in France, our genetic lab use in a daily practice gene panel strategy, which limits the risk of error due to the phenotypes overlapping. And you can see again what Elisabeth already showed us this morning, the frequency of the small vessel disease, which are identified in the genetic lab, NOT3 mutation from CADASIL patients are from far the most frequent, and you have far behind COL4A1 and A2 glycine mutations. So when the precise diagnosis of a small vessels disease of the brain has been made, what can we do? Due to the small number of patients, we have no clinical trials and very few evidence, so there is no recommendation, but we can, but it's possible to propose preventive and symptomatic measures, but they are mostly based on mechanism aspect and on expert consensus more than evidence. That is why there are no recommendations, but what we recommend in our center is to introduce an antihypertensive treatment in hypertensive patients, but in COL4A1 glycine mutation, we recommend to introduce this treatment if systolic blood pressure is more than 130, and especially after cerebral hemorrhage. Regarding antiplatelet, the treatment is not recommended, but in patients with an ischemic stroke, in case where there was no previous hemorrhagic stroke, we introduce antiplatelets after evaluating carefully the risk-benefit balance. Regarding anticoagulant, we recommend to avoid it, except in certain situations when there is a high risk of thrombosis or embolism, and if there is a strong indication as atrial fibrillation. And in COL4A1-A2 angiopathy, we begin anticoagulant only under very strictly blood pressure control. We also address lifestyle interventions, which means avoiding high-intensity physical exercise, as we saw that it could favorize brain hemorrhage. And we also address the aspects regarding pregnancy and labor, and recommend close follow-up during pregnancy, and to consider cesarean section for fetuses with COL4A1 and A2 cysteine mutation. Given that we have no recommendation for this aspect, and I have to say that every time we have very long discussion with the obstetrician before to take a decision regarding the realization of cesarean in these fetuses, mutated fetuses. In addition to these measures, we also realized in our center global management of the patient, including psychological support, even when no incapacity, taking into account the impact on relationships, and also support for the relatives which are at risk of being carrier. When there was a stroke, ischemic or hemorrhagic, rehabilitation support and the intervention of a social worker can be very crucial. We organize clinical and imaging follow-up during a day hospitalization every 1 year. Even this approach has to be validated, and during this day hospitalization, we realize brain and visceral arteries imaging to detect aneurysm, ocular and renal investigations. We also deliver disease information, especially with the SOS information card, and we address all the aspects regarding the relatives, including disclosure of genetic information, pre-symptomatic diagnostics, according to our local ethical rule. And this slide shows our pre-symptomatic genetic testing approach for relative of a patient or fetus having a confirmed diagnosis of COL4A1-A2. We deliver information during a genetic consultation or a multidisciplinary consultation with the aim to help the subject anticipating psychological, professional, and social adjustments to cope after the result. We inform them of the autosomal dominant inheritance pattern with incomplete penetrance, of the variable course of the disease. We explain that there is no treatment of proven efficacy, but that we can apply preventive measures, reducing the risk of hemorrhagic complications, and that genetic testing could provide medical benefit, including avoiding high-impact physical exercise and all the antithrombotic treatment, which are not recommended except in the situation that I have explained, that I have already explained. We explain also that this approach could conduct to organize a dedicated follow-up for detecting aneurysm and renal failure. We also inform of the possibility of prenatal and pre-implantation diagnosis to prevent the transmission of the disease. And this request is sometimes expressed by some families, some couple, when the disease was revealed by brain hemorrhage during antenatal or neonatal period. And the prenatal diagnosis is also proposed to determine, because it can help to take for decision making regarding the realization of a cesarean section for a fetus, for mutated fetus. So I have finished with the organization at the local and national level of the care of these patients, and I would like now to present you the European Reference Network for Heart Vascular Diseases, which is named VASCERN, and that we have joined recently. So the VASCERN network is dedicated for heart vascular diseases. It brings together 48 expert centers or affiliated partners from 19 countries, covering a large geographical area of Europe. And VASCERN recognizes also the importance of involving patients advocates. And in the network, there are now 36 patients advocates from 14 countries, which participate to a specific patients advocacy group. VASCERN is composed of 6 working groups dedicated to heart vascular diseases, including the neurovascular working group dedicated to 2 rare cerebrovascular disorders, CADASIL and Moya-Moya angiopathy, which is a condition affecting medium-sized artery of the brain. And we joined we created the neurovascular working group in January 2022. In addition, there are several transversal working groups for dedicated to specific projects, such as the pregnancy working group or the registry working group. And the VASCERN benefits also from the input of the patients group. The aim of this patient advocacy group is to have a larger representation of the patients across Europe to provide insights from the patients' perspectives. There are 2 patients representatives per working group to give patient perspective, and this group brings together 73 patient organizations, and 1 virtual meeting is organized every year. Our neurovascular working group started with only 4 centers, but it remains to be enlarged. These centers are located in Paris, in Milan, in Leiden, and in Essen in Germany. Larry Boiser is represented by Hugues Chabria and myself. In Italy, we have Anna Bersano, who is with her and who co-chair this working group with me, and Francesco Acerbi. Netherlands are represented by Saskia Lesnisk-Oberstein, which is a very known expert on CADASIL, and Julie Ruiten. And in Germany, we have Markus Kremer and Frank Dissner, who are involved especially in Moya-Moya angiopathy. The main objectives of FACERN are patients-focused. For example, one of the aim or one of the objectives is to share experiences, especially with countries where the expertise is less developed through a discussion of complex clinical case. We have also an objective which is to develop training and education programs through clinical practice guidelines, patient pathways, pills of knowledge, and do's and don'ts. And the development of European fair registries is also a priority of the network. This last slide illustrates the program, the FACERN program that we have developed during these last months. In a few words, do's and don'ts are comprehensive guidelines on the best practices regarding the diagnosis, the treatment, and the patient management. Webinar provide highlights for treatment, new treatment, and new aspect on diagnosis and on diagnosis. Patient pathways are standardized and help to deliver an appropriate care to all the patients, irrespective of their geographical location. And pills of knowledge are very simply understandable information which can be delivered to the patients and to the professional. Thank you very much for your attention.